Thank you for joining iMeet. This meeting is now being recorded.
Good evening, everyone. I'm Christian, coming to you from Oberlin University. And on behalf of my co-moderator, Dr. David Shaw from Harbor UCLA, we're excited to welcome you to another highly anticipated edition of our AABIP webinar series. Today's talk will be about one of our advanced bronchoscopic techniques, cryotherapy, which of late has drawn some attention due to an expansion of its applications. Before formal introductions today, I'd like to review a few housekeeping matters. First, everyone please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website and can be found under the Education and Training tab on the front page. Second, we ask that all participants mute their phones during the course of the webinar to minimize background noise and optimize the overall listening experience for everyone. Alternatively, you can use the volume control icon at the bottom right of your iMeet window. Now, to ask questions or communicate with the group during the webinar, please type them into the chat box. Now, this can be accessed by clicking on the thought bubble icon located in the bottom left of the iMeet window. We usually leave it up to the presenter to answer the questions as they appear during the talk. But we will keep track of the questions as they come up and have the opportunity to address them toward the end of the hour in a formal Q&A period. So please feel free to type in your questions at any time. Now, also on the bottom left is the projector icon. This allows the audience to toggle between the presenter's slides and any videos. And finally, a couple important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, I'd like to turn things over to Dr. Shaw for our formal introduction today.
Thank you, Ara. Today we're really pleased to have with us Dr. Sachdeva. He's the Director of Interventional Pulmonology and also the head of the fellowship program for interventional pulmonology at the University of Maryland School of Medicine. So thank you very much, Dr. Sachdeva, for joining us today. He will be talking about cryoablation for central airway obstructions.
Thank you, David.
So Ash?
Could you hear me okay?
Yes, we can. Thank you.
Yeah. Thank you, David and Era, for inviting me to speak. I know you guys put a lot of effort, and I commend you both for that in organizing the conferences as well as the webinar. So today, I'll try to review some basic concepts about use of cryotherapy for central airway obstruction. And I'm not able to see the advancer.
I just resent the control request to you, so hopefully it will work.
Got it. Thank you. So these are my disclosures. I do not have any disclosures related to the topic of the presentation. And as mentioned earlier, the opinions expressed are solely mine, and I'm trying to minimize my opinions during the talk. So the objectives of the current talk are to review the principles of cryotherapy, application in the airway, discuss various cryotherapy techniques for cryoablation, and specifically devitalization. I'll touch upon the differences in the terminology, discuss the cryotherapy used in management of central airway obstruction, and review treatment-related complications and their prevention. I'll provide some tips as we go along. This is the outline of my talk. I will review certain principles of cryotherapy, modalities of cryoablation, principally cryoprobe and spray cryotherapy, provide some safety tips, and review some complications. I will not be discussing cryobiopsy in this particular topic. Before we move forward, I wanted to review certain concepts of airway wall. As you notice, on the top left-hand corner, this is a cartoon of a cross-section of a trachea. It is approximately 2 to 3 millimeter. I want the practitioners of interventional pulmonary or bronchoscopist or proceduralist to appreciate the relationship of trachea with the esophagus. It's quite intimate, so to speak. There's not much tissue between the posterior wall of the trachea and the esophagus, and any lesion in this particular area, if ablated with higher energy levels, is likely to result in complication. Also, it is important to appreciate the layers of the tracheal lining and the wall. Here you can actually see the respiratory epithelium, the lamina propria. Together they form the mucosa, the submucosal tissue, and the hyaline cartilage. As we have evolved in the understanding of application of any ablative modality, we have started paying attention to the depth of injury as it relates to the depth of the tissue required to be injured. We have modalities such as balloon probe, and at certain centers, maybe in very early stage, optical coherence tomography that can help evaluate the lesion depth with a better tools. So how does the cryotherapy work? Peter Mazur in 1970 actually did a seminal paper, and in his work he described the rate of intracellular ice formation. So the injury typically happens as a result of intracellular ice formation, and as we cool the exterior of a cell, the membrane itself prevents the ice to proceed, or the ice head to proceed into the intracellular compartment. In this particular graph, if you're able to see my arrow, if you apply cold energy to a yeast cell at 100 degrees Celsius per minute decline in temperature, there is approximately 30% water loss from the cell at a temperature of around -14, implying that there is still not an ice formation, but a supercooled cytoplasm. So if the rate of change is slow, there would be almost no ice formation, and the temperature will stay at -4 to -8 until the entire water is seeped out of the cell. This is different for human red cell. It is important to understand this concept because the application of cryotherapy resulting in cell death depends on the rapidity or the velocity of the change of temperature. Likewise, in a separate experiment, the authors looked at the change in the temperature at the tip of the probe by putting some potentiometers. This one is put right under the mucosal surface. Another one is the 5 millimeter tip mark, and a third one at 10 millimeter from the tip of the cryoprobe. In this particular setup, they used a probe that was around 1.5 centimeter at the tip. But important to appreciate is this drop in temperature as the distance goes further from the tip of the temperature, implying that the temperature is lowest at the contact point. But as you move further along, the temperature drops. This can be mitigated by second or third freeze cycle. In this lower cartoon right here, if you notice the temperature change, although at the probe tip is minus 160 degree. As we go further along, approximately 10 millimeters from the probe tip, the temperature is only minus 30 degrees Celsius. This concept is important to understand as the temperature required to achieve cell death is studied to be close to minus 20 or below, and preferably minus 30 degrees Celsius. In a very interesting experiment that I would subsequently refer in my next slide, here I wanted to point out the surface temperature for different cryogens, especially if you use a cryo probe and put in a water that is at around 17 degrees Celsius. The temperature at the tip probe is not minus 80 for nitrous oxide. It is minus 50, meaning there is impedance of the ice ball itself, and the temperature around the environment is making it higher. Likewise for the argon, which is around minus 120 in this setup, and a liquid nitrogen around minus 160. Typically, the temperature at the tip of contact would be minus 196. Again, these concepts are important as you are applying cryotherapy for destruction of tumor to decide on the field of injury as well as area to be covered. In summary, the lower the temperature, faster the freeze rate, slower the thaw rate, and if you apply repeat freeze-thaw cycles, as seen earlier, with repeated application of freeze-thaw cycle, the temperature does get lower away from the point of contact. And then amount of tissue frozen. Certainly smaller the amount, better the contact, and better the application of cryotherapy. In this particular slide, I review the known mechanisms of injury for cryotherapy. So as we understand, the immediate effect is essentially extra and intracellular ice crystal formation. The more rapid change in temperature, or the faster the velocity of temperature change, it is likely to result in intracellular ice crystals. Slower the change, the cell death is going to occur both due to intracellular ice crystal as well as osmolar gaps between the environment and apoptosis resulting from that. Then there are delayed effects of cryotherapy, principally local vasoconstriction and thrombosis, which can start from as early as few minutes to typically few hours after the application. And recently there has been significant interest in potentiation of immune-mediated cell death or cryoimmunotherapy. In a very interesting study in canine model, the authors somewhere in 1970 looked at the morphological changes after a 5-minute freeze-thaw cycle in a dog trachea. What they did was they used a cryoprobe with nitrous oxide, and they applied the freeze therapy to 60% of the circumference of the 3 tracheal rings. What they observed was gross ulceration in 6 hours, meaning there was a complete perforation. However, there was a reepithelialization at 72 hours and complete healing after 2 weeks, implying that although there was a damage to the cartilage, there was a regeneration of the cartilage. And this was fascinating in terms of their understanding of the repair response after cryotherapy injury. At that time, there was a lot of interest in if this could be applied in airway, and this prompted some data to confirm that this could be possible. In another study, this is again in a dog model, Carpenter et al. Actually performed freeze-thaw cycle for 2 minutes each, times 3. This they protocolized based on some of their earlier work. But the authors were trying to look at if there is a scarring after the injury. So they performed a bronchotomy via a thoracoscopic incision in canine model. So they dropped the tip temperature to minus 160 degrees and around minus 170 degrees Celsius, both with application under the mucosal surface as well as outside the airway wall. They had the access to this aspect of the airway because they did a thoracotomy in the dog model. I depict a cartoon over here. Again, this is the tip of the probe, and they measure the temperature under the mucosal surface. And in the same experiment as shown earlier, they measure the temperature 5 millimeters from the tip, 10 millimeters from the tip, using a thermocouple. This is their modification of the cryoprobe after this experiment to be used through a flexible scope. The bronchotomy incision was about 3 centimeters, and they had control arm in which the dogs did not receive cryotherapy. What was impressive was that in both serosal and mucosal induced controlled injury, there was hyperemia and necrosis day 7, but there was a regeneration of the cuboidal epithelium, not ciliated columnar, in about 2 weeks. There was complete healing of the bronchotomy incision, although there was some visible surgical incision at 2 weeks. By 180 days, there was no significant difference between the dogs that received cryotherapy versus no cryotherapy. And impressively, by day 180, that's the protocolized sacrifice of the dogs, they had ciliated epithelium. Again, implying that after cryotherapy application, there is good regeneration of the tissue. In the subsequent reports, there was a single case report of use of cryotherapy in bronchogenic carcinoma, and then in the late 90s, a small case series about use in anastomotic stenosis. So, in summary, cryotherapy offers more favorable healing with preservation of tissue matrix. This has been studied by other authors in dermatological literature, bone injury situation, and there is animal data to support that there is positive influence on tissue repair with less fibrosis. More recently, this slide was kindly provided to me by Ellen Sheets from CSA Medical. This depicts what has been studied in the past with probe cryotherapy. As you can see with my pointer, there is an area of treated bronchus and an untreated bronchus in the same section. This is where the cold injury was performed, and you can see denudation of the epithelium, but the architecture underneath is preserved. And in this particular induced or injury model, there was no edema. In the cryoprobe model, they actually saw some edema and necrosis, but again, there's differences in how the energy was delivered and applied. But impressively, by day 2, there is a complete regeneration of the bronchial epithelium. And as you can appreciate, there is not a lot of inflammatory infiltrate, if you're able to see my arrow over here, underneath the epithelium. Again, implying the tissue repair is different compared to the heat energy. So what are the various advantages of the cold energy? Well, as we grew up, we remember our grandmother telling us to use ice pack when you get injured and you have pain, not a hot pack. So the various advantages are that it can be delivered safely at high oxygen settings. It can be delivered safely around the stents for that above specific reason. There is a minimal cartilage injury as we work in the airway compared to thermal injury. I haven't put a slide on the impact of weather, but Tim Murgu has an article with looking at the dissipation of heat energy and beautifully documented using optical coherence tomography on how there is impact on the cartilage. Of course, they did not study the regeneration of cartilage in that particular aspect, but they did demonstrate dissipation of heat energy. And further, there is a relative bioselectivity of the vascularized tumor tissue. So when I think of performing cryotherapy, since we have the benefit of having both the devices, I look towards, think in my mind about the type of delivery device I'm going to use. Of course, the cryogen, the delivery catheter. Currently, there are 3 or 4 different cryogen you can use. We commonly use nitrous oxide for cryoprobe and then liquid nitrogen for spray cryotherapy. What is the goal of cryotherapy? Am I trying to just achieve devitalization? I'm trying to provide or perform cryoaddition for a specific purpose. Of course, this cannot be done using a spray cryotherapy, and you need a contact mode. And do I anticipate, or am I thinking of some cryo remodeling? And I'll touch upon that in a little bit. And importantly, is this a malignant lesion or a non-malignant lesion that I am working on? Currently, there are 2 platforms that are commonly available in North America. There are additional platforms that our interventional radiology colleagues use for cryotherapy application and ablation in solid tumors. I have not put those over here. But principally, you have a console, a cryogen, and you have to specify the settings. We only have a single spray cryotherapy platform in the United States, and this is a cartoon of that, or picture of the platform. It is a pretty sophisticated computerized platform which actually calibrates the release of the liquid nitrogen, provides a self-directed guidance into cooling the catheter system before the application, and records the energy delivered, the time the cryogen was sprayed, and you can go back and get this information if need be. This is a picture borrowed from my colleague in gastroenterology. As you can see, the catheter is on the left of the view compared to a bronchoscope where it would be on the right side, and this is a 20-second freeze. This is an example of the cryoprobe unit that we have at our center. This is a Irby unit. This is a console with a gas cylinder and a wrench to release the gas valve. This goes through the console, and you have a pressure gauge and an electricity turn-off button. Importantly, the cryoprobe comes in this autoclavable tray. Of course, you have to purchase the tray, and this is a 1.9 probe with a cap. The cap has to be put on before autoclaving to prevent any damage to the gasket. This is how we set up the probe. When the gas valve is not released, you'll see the pressure monitor in the yellow zone. You open the cryoprobe unit, lefty-loosey, righty-tighty, lefty-loosey, and then you attach it to the console unit. You'll release the valve for the gas to fill in the system, and you'll see me pushing on the foot pedal right here, and a blue light turning on, and the manometer gauge telling there is an adequate pressurized gas. I intentionally put this slide to show that this is a 2.4 millimeter cryoprobe. When frozen with an extended metal of around 7 millimeter, the ice ball is always going to be around 1 centimeter. But as you continue to freeze for a longer time, the volume of the ice ball gets bigger. This is a 120-second freeze. Looks a little bit bigger, but the length is according to the contact of the metal. Again, highlighting that the farther you go from the contact or the tip, the temperature change is going to be, or the temperature is going to be different than the tip temperature. The cryoprobe has certain limitations. We currently don't have any temperature probes inbuilt, so you don't know what is the temperature that the tissue is seeing during application. We don't know what's the temperature at the perimeter of the ice ball. You can't just function with one probe because there could be challenges in terms of egress of the gas or liquid droplet formation. So spare probes are essential. If the pressure drop in the cylinder during the procedure is rapid, then there could be a significant change in the temperature. And the current cylinders are small, so it's a small capacity. This is an example of the spray cryotherapy unit. This is a 7-French spray cryotherapy catheter, and the liquid nitrogen is available at most hospitals, or all hospitals, in the form of these medical nitrogen tanks, and you have to fill in a smaller tank that is inbuilt in the system. This cartoon demonstrates the application of spray cryotherapy via bronchoscope. Currently, the spray cryotherapy is FDA approved for destruction of unwanted tissue in the fields of dermatology, gynecology, and general surgery, and the pulmonology falls under this umbrella. And the current system is approved for use in the airway. This is not an off-label use as it used to be before 2007. Important to understand that there are subtle differences in the delivery of the cryotherapy. As the liquid nitrogen egress occurs through this distal tip of the catheter, there is a rapid expansion of the gas to the order of 1:645, approximately 700. So there is a rapid expansion of the gas. So you need to have a good egress. However, with the same principle, as the gas is being released, there is a very rapid drop in temperature to -196. And as I noted earlier, the faster the velocity of change, the faster the intracellular crystal formation, and this relies more on the formation of the intracellular crystals, thus resulting in cell death. Also, it gives an opportunity to cover a bigger surface area. For example, if the stalk is 5 millimeter and you want to extend the energy delivered 5 millimeter radius around the lesion, it is much easier to do the paint motion and perform this. Although the typical depth of injury is 3 to 5 millimeter, the ablation itself, or the depth of the unwanted lesion, is not, is dependent on the time of application of the cryotherapy. This is directly from the manufacturer's recommended energy delivery timelines. For example, on the top of the left hand in the green box, this represents 20-second cycle for ablation or devitalization in Barrett's esophagus with high-grade dysplasia. And you can see there is approximately at 25 watt, which is a normal flow setting for this particular device, you deliver about 100 joules of energy. So people who are more familiar with laser application can relate to the amount of energy in equivalent terms. For airway application purpose, typically you will perform 3 to 5 cycles of 5 seconds, and the time to count those 5 seconds starts after the freeze or the white frozen zone is seen up to 50% of the area to be applied. And as you can see, there is depth of injury is a little bit different. Personal communication with Dr. Greenwald, if you do this application for up to 60 seconds, you can perforate the esophageal wall in an animal model. So you can induce transmural cell death. So it's important to understand the concepts as well as the amount of energy to be delivered to prevent any harm. Again, what are the limitations? You need a very good egress for the nitrogen gas. And I depict this with a cartoon. You need at least a size 8 endotracheal tube, and the manufacturer actually provides a good flow as well as egress measurements. But for purpose of simple understanding, if I have an 8.5 endotracheal tube and a 6 millimeter or 6.3 millimeter scope, I have about 2+ millimeter distance between the wall of the scope and the endotracheal tube. And if you deflate the cuff of the endotracheal tube, you get additional few millimeters, and the gas will vent out, a pressurized gas will vent out to the path of least resistance. My particular preference is using a rigid scope, as it provides a bigger pathway for the gas to egress, plus a straighter pathway. Although you could argue that if you combine the lumen that is available for the gas to egress, especially if you deflate the cup, they probably become equivalent. However, as I mentioned, this is our preferred way of delivering spray cryotherapy. Again, the complications that have been noted include pneumothorax, hypoxemia, which may be either due to replacement of the oxygen molecules due to nitrogen gas, or it could be related to gas embolism. And with the older system, that's where the authors used as an off-label device, deaths have been reported. But to my knowledge, there has been no deaths with the newer delivery system. With this background, I will share some cases as well as literature surrounding the application of the cryotherapy. A very common use of cryotherapy is using the cryoaddition principles, and it works best for organic food particles. And this is an example of a hot dog. Blood clots that are very cryoadherent. Anything that has water content, it will freeze, and you can extract those. This is an example of devitalized tissue, and in this particular case, we were able to extract the endobronchial aspergilloma. Recently, we did a case where there was a complete obstruction of the left lower lobe, and we removed a mucus cast that supposedly does not have a lot of water content. However, we were able to freeze with a 2.4 millimeter probe and extract it in a laborious manner. Importantly, I wanted to highlight the coaxial placement of the cryoprobe, and that's the fundamental important aspect of doing a bronchoscopy when you're using this particular device. When we have to do ablation or devitalization of any tissue, we look at the cause of the abnormality, whether it's in situ cancer or tumor debulking is needed. Do I need to use heat energy, either laser? Would the patient be a good candidate for photodynamic therapy? Or I need coagulation with APC. And then, importantly, I've started paying attention on how the tissue is going to heal, and is that meaningful in the right context. When you look at the application of cryotherapy, earlier authors or authors who actually worked with a cryotherapy probe in the past looked at cryotherapy application. In this setting, the authors principally used the cryotherapy as a modality to ablate. So they did 3 minutes freeze-thaw cycle times 2, either 2 sessions or 1 session. And then in this particular study, the authors actually went back and looked at and compared the 2 groups where their practice was to do 1 session of 3-minute freeze-thaw cycle times 2 versus 2 sessions where it brought the patient back. They found that patients who had 2 sessions had better outcomes or trend towards better outcomes But importantly, patients who received radiation therapy and cryotherapy had an improved survival. However, this was focused principally just on cryotherapy application as a modality, just like we would do heat energy. However, if you combine the principles of both cryotherapy application and cryoaddition, you can achieve tumor debulking. So in this small study, the authors actually looked at the impact of cryorecanalization. They had about 60 patients. Most of the tumor was exophytic tumor, where they could actually freeze and then pull the tissue out. Again, in this particular situation, the freeze cycles was somewhere between 3 seconds to 20 seconds, depending on how much tissue they wanted to extract under direct visualization. There was mild bleeding in 54 patients of 60, which stopped spontaneously. And in 6 patients, there was a more intense bleeding. The authors contend that it would have stopped without any intervention such as APC had they waited longer. And all these patients were done with flexible bronchoscopy. So they demonstrated that it was safe, and they were able to achieve complete recanalization in more than 60% of the patients. In the same group of people in Rogers' study, where they collected this data prospectively, they looked at the success in 225 patients, and they were successful 90% of the time. Again, mild bleeding in 4%, moderate in 8% requiring APC, highlighting that you may want to have, or you should have, a coagulability modality to cauterize the bleeding, or maybe tamponade with glue, as I'll show later. But clearly, it's a safe technique with high success rate. So what are the advantages of cryorecanalization? Of course, you don't have to go back in and debulk the tumor after it dies in a few hours to a few days. It's immediately effective. If you're using cryotherapy as a sole modality, then it's certainly cheaper. You can reach the distal disease. You can work in sicker cohort where you have to maintain higher oxygen concentrations. And then, as noted earlier, there's low risk of complication. In this particular patient, we had left mainstem exophytic lesion which had a very broad stalk at the base. We snared a little bit on the top, but the rest of the debulking was done with cryotherapy. This is a CRE balloon that we inflated to tamponade the bleed and then kind of progress with cryotherapy debulking in a meticulous manner. While there was a good bit of interest in cryoprobe, at the same time, there was a progress made in the GI literature where they use spray cryotherapy for high-grade dysplasia. This was an impressive data from Bruce Greenwald at our institution, in which they actually had 90%, I think 97% success rate with Barrett's esophagus and high-grade dysplasia. And they had 70% eradication with T1 esophageal cancer. This is an example of high-grade dysplasia in a Barrett's, and this is, again, an example, and 20-second freeze cycle times 2, where they had to bring the patient back to redo a cycle, and then this is after treatment 2, where there was no evidence of any disease. So we have learned from the GI colleagues on its application when the disease is limited to the mucosa or the submucosa. Further, I wanted to point out that there is impressive literature, at least studies done in the past, and more recent interest in immune augmentation with cryotherapy. So does the cryotherapy provide tumor antigen to the dendritic cells, and then they activate and work in the similar fashion as the PD-L1 antagonist. We don't know, but there's a lot of interest, and I would refer to a paper by Daniel Katzman and Dan Sturman that's published recently in JTO if anybody is interested and has a desire to read more on this. But in this particular study, they use a mouse model where the tumor was implanted, the mouse got chemotherapy and a cryotherapy application on the other metastatic site. And as you can see, there was no reoccurrence of the tumor. And similar observations were made when a radiation was done in this mouse model. So I wanted to go back to the slide. Sorry about confusion on my end there. So is there a data for cryotherapy application in early superficial bronchogenic cancer? So the authors here looked at its application in patients who were diagnosed with early stage bronchial carcinoma. This was a small series. What they noticed, there was about 20% multifocality of disease. And this cartoon describes the areas where they found the tumors. In this particular series, they had about 28% reoccurrence in a year time. But 40% of these reoccurrences occurred at a distant site from the primary site of cryotherapy. Even so, it raised a lot of questions. Was the devitalization depth enough? Would another technology that has a deeper penetration work better? Raising some questions. And nevertheless, it's important to recognize that that cryotherapy has use in early superficial bronchogenic cancer. This is an example of a patient where this is a cricoid cartilage right here, and this is a mucinous adenosquamous, not adenosquamous, mucinous adenocarcinoma diagnosed after tissue biopsy. The patient presented with symptoms of cough and hemoptysis. She's not a good candidate for surgical resection, or we are still debating, and we were able to evaluate the depth of invasion by endoscopic ultrasound done simultaneously at the time of bronchoscopy. So we decided to do a cryotherapy application while we are reviewing the treatment options, including photodynamic therapy. But this is to highlight how you apply a cryoprobe in a tangential direction. You do freeze-thaw cycle. You can see the ice front expanding. And then we were able to do some cryo debulking, so to speak, to denude the mucosa. There was bleeding that was controlled with APC. However, at the end of the procedure, you can see we have almost taken out the mucosa down to the submucosa and the muscle layer to the entire stalk. There has been a good bit of literature in treating the endoluminal endobronchial carcinoid that are typical, not the atypical, or in patients who were not a very good candidate for surgery. So there's a good bit of data with YAG laser. In this particular series, there was small volume pedunculated tumor, and all patients were free of reoccurrence. Again, small series, YAG laser with photodynamic therapy, or mix of all these, implying that if you ablate the stalk after removing the tumor or the base, there you can achieve good results, as there is not a lot of depth to the carcinoid tumor. I did not find any literature reviewing in particular the depth of invasion with a typical carcinoid, but in general, and I'm talking specifically for the airway carcinoid, But in general, there is not enough depth, and you can achieve complete ablation. So why not cryotherapy? The authors here looked at typical carcinoid. They were strictly endoluminal based on radiographs as well as absence of any lymphadenopathy, and they performed 3 cycles of 20-second or 30-second, depending on the center as well as the size of the probe. In about 18 patients, there was only a single reoccurrence 7 years post-endoscopic treatment. Again, suggesting that cryotherapy is meaningful in carcinoid. This is an example of a young woman who presented with massive pulmonary embolism, had a sudden cardiac death, resuscitated, put on ECMO, and doing a routine bronchoscopy for blood clot removal, there was an area seen in the distal left brainstem. Given her comorbidities, she was not a good candidate at that time for sleeve resection, and this may not have been feasible. So she underwent, after a TBNA biopsy, demonstrating on site that this is a tumor, complete debulking was performed, followed by cryotherapy, and then application of APC for the control of mild wounds. This is 2 months later. We wanted to bring the patient back in 4 to 6 weeks. We did a narrowband imaging, and there was what appeared to be an abnormal response. The biopsies here did not show any reoccurrence of tumor, and the patient is on follow-up for surveillance endoscopy or bronchoscopy. Another example where the patient had a typical carcinoid for 5 years. She had obstructive features, but did not present until she had a pneumonia, and this was ablated, and you can see a fibrotic change over here. We did perform, in this particular situation, a radial EBUS at the time, and you can see a little bit thickness, and this concerned us. However, a follow-up CT imaging demonstrated a normal airway wall, and the patient is due for a follow-up. Another application of cryotherapy is removal of granulation tissue. In an earlier study by Maywand in United Kingdom, they actually have a transplant center, and they perform cryotherapy in benign central layer obstruction from granulation tissue with excellent results. They performed a 1-minute probe application. In this particular image, we performed spray cryotherapy for granulation tissue in a patient with hourglass silicone stent. This is a few weeks later, and this patient did not require any further treatment for granulation tissue, and she's about 5 years out and currently in the process of getting stent removal. Again, some challenges with her surgical resectability. There has been quite a bit of interest in use of spray cryotherapy, and this small retrospective series in patients with non-malignant strictures reflected that the patients require repeated sessions. However, they had improved symptoms and also 2-grade improvement in the stenosis. And I think we have an opportunity to look at this group of patients where spray cryotherapy may be meaningful. I provide an example of a patient where I would have preferred to use a spray cryotherapy in a woman with granulomatous with a scarred or subglottic stenosis. Actually, it's subglottic, but above the cricoid. There was no active inflammation. We performed a cryo probe application. As you can see, a little bit change captured right after the freeze cycle, and then a very, very gentle balloon dilatation. This is a freeze zone there. This is an example of contact cryo probe application. And then she needed a little bit of a release with an electrocautery knife of the stricture and subsequent balloon dilatation, but minimal repeat injury or minimal injury to the mucosal surface. again, with good results. Again, you can choose what type of application you may want to perform. This is an example of post-radiation stenosis of the left roller robe. I'm upside down. This is the upper, this is the lower. And we did a wrong cycle of cryoapplication. It's very, very difficult to get results with a well-formed scar with cryoapplication alone. But with patients, we were able to gently balloon dilate and able to pass a 4-millimeter hybrid scope. This is an example of pulmonary hematoma that required electrocautery snare and subsequently removal of these large tumor with cryotherapy. So in summary, I would say that cryotherapy is a well-studied devitalization modality for airway lesions. There's a good bit of data for safety, repair of tissue subsequently. Both contact and spray cryotherapy have their unique advantages and challenges that we need to understand and use accordingly. And there is much need for collaborative research to assess outcomes in malignant and non-malignant diseases. With this, I'll be happy to take any questions and give the podium back to Dr.
Before we continue, Dr. Sachdeva, did you want to review the videos that you have as well?
I think we have time. It will take about 1 minute, 30 seconds if we could do that.
I think it might be a worthwhile thing. So I can start playing your videos if you'd like to narrate over them or annotate on top of that. Does that sound okay?
Okay. Yeah, thank you. So this is an example of, or a video depicting principles of cryoadhesion and keeping this probe coaxial. As you can see, I'm rotating the scope right, and then as it freezes and I get maximum surface contact, I am pulling the probe and the scope back all together, and we're getting this large mucus plug. I continue to freeze as we are coming out to the endotracheal tube. We can go to, this video is going to be available for anybody's review. We can go to the next video. In this particular motion, I'm depicting that there is a 2.4 millimeter cryoprobe. As I perform the application, there is, as you'll see now, as I pull back, there is too much freeze and I can see the blood coming from the tissue. So here I stop. I did not continue pulling with the cryoadhesion. I let it release, thaw, and then redo it. So don't do this mistake if you're doing, or just stop. The third video is, which I'll request David to play, depicts application of spray cryotherapy for a lesion. I wanted to thank my colleague in otolaryngology, Dr. Guardiani, who shared this video. So this is a cryoprobe, spray cryotherapy catheter. You can see the mist, the gas is exiting, and the application is done for the right vocal cord lesion that was biopsied. I do not have a video on this of the recovery, but what is impressive to understand is that we have done about 5 or 6 patients, and there is no injury to the vocal cords. The patients preserve their vocal cord function and mobility even after the cryotherapy application, and we have follow-ups for these patients over a period of time. So thank you, David, and thank you, Era.
Great. Thank you, Dr. Sachdeva, for really a very nice comprehensive review of applications of cryotherapy. You really took us from its rationale at the cellular level to its clinical applications. Just in the few minutes we have left, let's review a couple questions. The first one actually is a combination of one of the questions from the audience and a question I had. It regards cryotherapy's use for benign airway stenosis, and you kind of touched on this toward the end. Now, its benefit for granulation is more obvious since the tissue is, of course, fluid-rich, but I'm intrigued by its use for fibrotic strictures. Do we have data suggesting cryotherapy is successful in preventing fibrotic stenosis recurrence? And if so, how do you hypothesize this may be working at the cellular level? Is there a modulation of fibroblast function or other immunomodulatory effect of the healing pathway, or is it simply that cryotherapy may not be triggering additional injury, as may be the case with the application of electrical energy?
So, very good question. And I'm happy to hear from anybody who has more expertise on this, but there are two aspects of management of benign airway stenosis, and I think one has to specify when we look at the literature whether this was a continuum of injury of active inflammatory tissue, as you alluded, like granulation tissue and a fibrotic tissue. In one of the pictures I showed you, there was a well-evolved scar. And I think in that particular situation, the benefit of cryotherapy may be more due to the fact that we are not causing a secondary injury or secondary insult. Or if you did cause a secondary injury, the repair may be altered. There is one rabbit model study where they actually did a cryo balloon application, and they generated a tracheal stenosis model, again, a short period of time, meaning a young injury, where they demonstrated that there was decrease in fibroblast proliferation. So that's the only animal model study I know of that has looked at it. I think the second part you asked was, what is the mechanism of using cryotherapy in an evolved scar? I do not know. People have postulated that as you perform a cryofreeze, there may be some mechanical or physical property change in the tissue that lets you do the balloon dilatation without causing a deeper mucosal tear. Maybe it changes the elasticity or the physical property, and by virtue of that, you can expand that. I don't think we have good data to understand that. There's no question. If you have,
I'm sorry, go ahead.
But if there is a predominant granulation tissue, that certainly responds to cryotherapy application, and we have a good bit of data to support that.
Excellent. Very intriguing. I'm looking forward to more data in the fibrotic stricture setting. I think we have time for one final question. It regards cryogen differences, particularly carbon dioxide versus nitrous oxide. Are there differences in the cryogens themselves in terms of both application as well as result, differences in the delivery method, including any probe differences that are present as well?
So, in my review, there was no comparative study to look at this, but there are definitely theoretical as well as some data based on prior studies. For example, I mentioned the spray cryotherapy. So it induces a very rapid change in temperature, meaning the velocity of change is quite rapid, and it almost traps the water and causes an intracellular freeze at a pretty fast rate. So that results in intracellular crystals. So you can define the time of energy delivery, define what you need to cause the devitalization. With a cryoprobe, you actually rely on what is the temperature change in the perimeter. Do you have a 2.4 millimeter probe versus 3? Are you using a rigid probe at certain centers? We don't have a rigid probe. That could be as big as 5 millimeter. So the contact surface will impact the temperature change. I don't know if the cryogen per se, other than the the change in temperature would make a difference. For example, our interventional radiology colleagues use argon-based cryogen systems, and they drop the temperature pretty quickly as well to minus 160 degrees Celsius. And they have a very different protocol for ablation of intraparenchymal tumors. So their protocols will dictate a freeze time of about 3 minutes, 7 minutes, and then 12 minutes, meaning the total freeze time is approximately 20 minutes. So is that a cryogen difference? I think it's more based on, or at my understanding, is more based on the temperature achieved or the size of the lesion you want to ablate. So typically a Barrett's high-grade dysplasia, if I have to give a perspective, is 0.25 millimeter depth of injury or cellular devitalization you need. So very different from a centimeter of tumor that you're trying to kill.
Excellent. Thank you for that extremely detailed input, Dr. Sachdeva. We're officially out of time, but for those of you who have additional questions, you can stay online after the formal close of the session. I did want to, before we leave the session today, I wanted to turn it back over to Dr. Shah for any final announcements.
Thank you both. Just for an FYI for everyone, keep an eye out for the next AABIP webinar, which will be, our speaker will be Dr. Scott Ferguson from the University of Wisconsin. He will be talking on July 23rd about the usage of clinical genomics and risk stratification of lung nodules. So at this point in time, we're probably going to run out of recording time, but that's okay as long as you're willing to stay on board and as long as Dr. Sachdeva has time to entertain any additional questions, I think we can continue. Thank you.
Thank you again, David and Era, for organizing this. I know a lot of time and effort went into this, and I commend you again for that.
We appreciate it, Ash. Thanks for coming on.